Hi, everybody. Welcome. My name is Amanda Muller with NASTAD's Drug User Health Team. So this is our question and answer kind of office hours type session on all things drug checking related and fentanyl test strip related. So I'll let our panelists introduce themselves in a minute, but over the past couple of weeks, we've done a few webinars on fentanyl test strips and advanced technology drug checking services. So those have been recorded and they'll be posted on our website later this week. And we haven't had much time for discussion or questions at the end of those sessions. So we wanted to host just like a space for folks to ask any questions related to providing these services to folks and participants, to implementing these programs, ways to protect participants, types of funding, any type of questions like that. So I'll let our panelists, experts introduce themselves, and then we can really just wanted to have a discussion. So if folks have questions, we're going to open it up for people to just ask questions, and we'll go from there. So I'll hand it over to Maya.
Hi, good afternoon, everyone. It's really nice to see you. My name is Maya Doe-Simkins. I am joining you from Northern Michigan. I've been working in public health and harm reduction for about 20 years. I spend a lot of time on expanding access to naloxone, but I also am one of several co-coordinators of the Alliance for Collaborative Drug Checking and have helped launch advanced technology drug checking projects in the US. And really happy to be here. Looking forward to this conversation. Yara-Lise, do you want to go?
Sure. Hi, everyone. My name is Yara-Lise. I use she, her pronouns, and I'm located in New York City. I'm a special projects coordinator for the New York City Department of Health and have been doing drug checking in an official capacity here for the last year or so, and started doing drug checking some years back through Dance Safe, and have done other harm reduction projects in the last, 7 years or so. But nice to be here, and I'll pass it to Sarah.
Thanks. Hey, everybody. This is Sarah Mackin. I'm the Director of Harm Reduction Services for AHOPE, which is the Needle Exchange SSP under the Boston Public Health Commission, which operates as the Board of Health in Boston. And my favorite role in the program is, as drug technician and outreach worker around this intervention. So I'm really excited to, answer any questions that we maybe didn't have a chance to answer the last couple of webinars.
Awesome. Thank you guys so much. I'll start off with like one or two questions, but if folks have questions, put them in the chat or go ahead and unmute yourselves. I'll just start us off with like one or two questions for now. So one of the questions was about types of funding or structuring a budget to implement like drug checking services, and what needs to be in that budget, what kind of things do you need to provide funding for, and then what funding resources are available or that you guys have used.
I can jump in first. We initially were able to secure like private foundational funding to get our first device, which was the mass spec. And then, realized when that wasn't meeting our needs that we were able to convince the funders that some of the remaining funds that were unspent, we could buy an FTIR. So we initially started out with private funding. That's what's been keeping the intervention going for the past 2.5, 3 years. We have just recently gotten word from the Bureau of Substance Use Services, which is one of our funders from the Massachusetts Department of Public Health, that they will actually fund our mobile drug checking program by allowing us to purchase the machine. Doesn't pay for any of the staffing, but we're gonna kind of train remaining staff. But yeah, so I can speak to the funding piece of it. In terms of budgets, I think it looks different depending on what machine you're going to go for. I think we kind of talked about some of the pros and cons in the last webinar about the different types of advanced checking technology. But in general, so our program, after we moved away from using the MX908, which is pretty costly at about $65,000, and it has significant ongoing costs, including technical support from the company, and also each test requiring multiple swabs and these sort of Q-tip looking things that you use to kind of scrape residue off of paraphernalia, which can get very expensive very quickly, not to mention like repairs or any other issues that you need. So once we moved away from that, we purchased the FTIR, which was around 35,000, 40,000, depending on which sort of specs you get. Comes with a laptop, it comes with the machine itself. Always buy the hard case. We didn't put that in our initial, sort of like proposal, and didn't end up getting one. And thank God somebody, one of our people in Chicago was able to send us an extra one so that we could actually move it around. We did get through the private funding. We were able to fund one full-time drug checking coordinator at a coordinator level. And in terms of like budgets, that's like additional to like the one-time cost or purchase of the machine. It's really important. It has been really critical for us to be able to send out samples to drugs data, which uses the LC-MS technology for secondary verification, secondary testing, which can get expensive. I think it's like upwards of like $150 or $170. We're actually partnering, thankfully, with one of our research collaborators who's able to pay for that. But that is an absolute must for anybody that's going to be, kind of learning the FTIR. It helps to validate what the technician is seeing. It also helps kind of get a 30,000-foot view on, some of the maybe smaller quantities of things that the FTIR won't pick up on, like benzodiazepines we talked a little bit about are usually potent in very small amounts, or something like synthetic cannabinoids, which are also very potent and have serious kind of psychotropic effects that you wouldn't necessarily catch on the FTIR because they're present at such low concentrations. But, it really depends on your volume, how much you're going to budget for that. But I would say, I think Jalix has a pretty well thought out budget. Maybe you can talk a little bit about confirmatory testing and like what you guys have built out.
Yeah, sure. I'm looking for the like line level stuff, so I can pull it up in a second. But we currently have 3 machines. I think if you tell them that you're a harm reduction organization, then you're doing it for harm reduction and not for like lab stuff, I guess. They give like a 10% discount, and it comes out to maybe 32,500 or so for the machine alone. And then, oh, that's my boss. 1 second.
May I say something real quick while we're waiting for her to come back?
Yeah.
Hi, this is Pauline Maldonado. I'm calling from Albuquerque, New Mexico. I realized that my question was kind of vague about getting points of reference or advice for us as we're about to start. I guess one of the things that we're really looking forward to is connecting with our forensic labs so that way we can send confirmatory to them. We haven't had a meeting with them yet, but I'm hoping that we can go that route. But if we're not able to, is drugs data like the next best thing at that point possibly, or what do you advise?
Maya, do you want to jump in here? I'm happy. I've had a wonderful experience with drugs data. I also know that, they're very overwhelmed. They do a lot of volume. They're a phenomenal partner, but, I think as more FTIRs come online and more samples are coming in, I think that, like I believe they only use one lab. So I think that sometimes that can result in delays, although they do a wonderful job. So I think that anybody looking for confirmatory secondary testing or secondary verification would do best to have someone relatively local. Like my dream would be able to like pack up a sample and be like, I don't know what's going on here. I really want to give one of my people like some quote unquote real-time responses about maybe some of the smaller things that the FTIR isn't catching, and be able to drive it to a lab and, get an answer in a couple of hours. That would be ideal, right? So instead of sort of like 10 days out, sometimes 14 days out, and depending on the sample and depending on their volume, sometimes it takes a little bit longer. But Maya's known them for longer than I have. But if you want to jump in there.
I think that, whatever you can get to work for you is good. The one thing that is absolutely essential is that your schmancy lab has to have experience with illicit drugs. Like if they don't, there truly is like serious opportunities for things to get screwed up. And what you get with the Arrowhead crew and the drugs data crew is decades worth of very deep drug experience, right. and not only, and they're like sort of psychonaut nerds. And if there's something that's weird, like in certain situations, they have activated their entire like global network of other, like, deep down in there, like seriously, seriously nerdy psychonauts. And so I feel like if there's capacity in the absence of like less expensive or more local, like Sarah's talking about, my opinion is they're an excellent resource if they have the capacity.
Okay. As far as the FTIR machines, is there a certain brand that she was talking about, Yada Leaks was talking about? Because we're looking at spending between about 35 or 40,000 a piece as well. Is there only like one type of brand? I think Brooker's is the one that I've seen the most.
There's different types. Go ahead, Maya, you go.
Yeah.
Okay.
I mean, in the same way that we're not like necessarily endorsing BTNX for fentanyl test
Right,
strips, like
yeah.
it's not like we love Bruker per se, but what Bruker comes with is two things. One is that is largely what most everybody's using. And so it's
Okay.
really easy to join in a learning community with other folks who are using like kind of the exact same thing. There's absolutely cheaper FTIRs, like Shimadzu has one, for example. It's in the mid to high teens. But the other thing that Bruker brings is their software, which is
Right.
a little bit wacky and clunky in terms of an interface, but there's this, but it's probably the best for lay person leaning programs out there. So that's the benefit of the Bruker brand. So, and you know, no fidelity to any like capitalist, you know, companies per se.
Yeah.
Anybody comes up with something better and cheaper, like we're on it. But at this moment, just the continuity of joining a learning community is really meaningful, because it's a steep learning curve. And so, you know, the part that I think that it's doable, but it's steep, and the pieces from budgets that folks kind of like overlook are one, secondary testing, two, fentanyl test strips, like you got to budget for those, but three, the person power. Like we really can't expect existing syringe service program staff to fully absorb that work. Like there does need to be a carve out, and it may not necessarily need to be a complete FTE, but I think if you can, it would benefit from that. It's just not a add on to existing work kind of role. So.
Okay, awesome. Thank you.
I would say too, like, I mean, I do kind of worry about, you know, the drug checking community like getting locked into like just using the Bruker. But it's so critical for, at least for me, it was really critical for me to be able to compare apples to apples. So, you know, for example, you know, like I've sent scans to Jetta Leaks and been like, what am I looking at here? Like, this is what I think I see. Am I crazy? And then she can kind of rate me back in Slack and be like, I see a whole lot of craziness too. And we can kind of compare, and it is really, really important, that sort of learning process. And I think you also put in the chat, like a question about, you know, where do you start with learning? The British Columbia Center for Substance Use has a really great guide that they've been really liberal about sharing and putting out there. There's also a series of videos on YouTube where Sam, who is someone who we actually contracted with, like, you know, as a TA consultant, where we would send scans to him, ask him to kind of work us through some or troubleshoot issues that we, you know, had come up against. That was really critical. But, you know, there were a lot of like, there's some paper-based or like, you know, sort of like actual resources you can reference in sort of the beginning stages of training. But once you get the basics, it's really critical to be able to like rely on either like a consultant or somebody that you're able to kind of like send stuff to and say, can you take a look at this? What do you see? That community of harm reductionists who are doing this work has been critical in like our own education, our own development, implementation of the program.
Very awesome. Thank you both.
And somebody else asked in the chat, what does drugs data typically charge?
I think it's very, I think there are some exceptions, but I think right now what the samples that they're processing for us in this other you know, big research project out here in Massachusetts and New England is about like 150 to 170, if I'm not mistaken. So it does get expensive quickly. And I actually don't even think that covers their full cost. Like it's expensive to do what they're doing, and they're not getting rich off of it. And I think they make a lot of exceptions, and, you know, have even said to us when we first started out and didn't have, and I'm not promising they will do this for you, but they've been wonderful in being like, listen, like we could probably give you a couple of envelopes for free or whatever to send out. But you know, I can't stress enough like how important it is to budget out wherever you're doing secondary verification on an LCMS, GCMS, or another machine, to have that money available. But it is expensive. It gets expensive.
So in Seattle, this is Rachel, and I'm doing testing with People's Harm Reduction Alliance. I just got through the technician like webinar series and have been doing like my first testing, and it's super exciting. So we had a pretty good relationship with the crime lab here, but the person who was the scientist doing the technician like testing there is actually leaving her position. So we're like crossing our fingers that it's going to be somebody that is like not super shitty drug war person, but like, do you have any suggestions for like building a relationship with like whoever those people are? Like, any suggestions for just like, yeah, having a relationship with a crime lab in order to like do confirmatory testing? Because we have no, I mean, nobody's even paying, we don't even have budget to pay technician. Like, I'm doing this all voluntarily right now, so like we truly don't have money for like confirmatory testing as far as I know right now. So, but we want to be able to provide it, and we can do it for free theoretically through the crime lab, but now I'm just like, you know, worried about that relationship. And
I think you're really right on to be worried about that relationship. And my first suggestion would be to ask your colleague who's leaving, who you trust, like for any guidance within the crime lab. But going
I
in,
think we've already done that, and they are
yeah,
willing to consult with us. Yes.
yeah.
So that is,
Yeah, I mean, like, not only are you really reasonable to be concerned about that, but the other thing that we've seen happen with too much deep involvement from state crime labs is all of a sudden some of the folks who operate the lab, who are very much like, you know, chemistry lab, you know, folks get freaked out by the way in which we are not following lab protocol and start like meddling with regulations within the state. And like, actually there was a period where one of the programs I was helping got interrupted because then they were like, whoa, you can't be doing this. And so it's not only just like the individual and believing that they're gonna, you know, come at this with the right mentality, it's also that like there's also a risk to interrupting services if like the wrong person gets sort of you know, offended by the liberation of this technology for field use or something like that. So yeah, I guess I'd say I think that's reasonable. And you know, both state and federal and philanthropic, but state and federal funds can be used for this. And right now there's a lot of federal funds. And I mean, I feel like my first thought is, why on earth is, you know, why are funders giving you money to buy extremely expensive equipment and not the additional necessary components of that budget? And there's really no excuse for it. It other than perhaps they didn't quite realize how much it was necessary. And there is money. And so I would also like just sort of suggest pushing back on some of the budgeting that has been done at the state level with the federal funds, because I don't know of a single state that isn't like underspent on their SOR funds, for example. And so perhaps that is another approach to consider.
And ADA, yes, we are like, we're dealing with that piece, and hopefully there will be funding, but like, it's a process of red tape.
So I wanted to bring up, there was something in the chat about it, and it kind of feels like two different questions. So one is around legislation, which I know we kind of talked about the other day. So, you know, the question about like model legislation regarding test strips. So I think first what we had talked about was like not having it more broad than just test strip specific. So more drug checking services, but any legislation that would be introduced or passed around drug checking would need to ensure protections for participants, not just for program staff implementing these services. So I didn't know if there was anything you wanted to elaborate on about that. And then I have like another question about participant protection when actually implementing these programs after that.
So like Sarah said, there is the ONDCP has commissioned a model legislation document that is forthcoming. I would imagine it would be out in not too much longer, within a couple months. And so just given that has the kind of weight of being released by the feds, and it mirrors some of the model legislation for standing orders. It's, I mean, just like in terms of look and feel, I feel like that is probably a good place to start. And honestly, I looked at it before it, so did Sarah. I think maybe Yada at least did too. And I was expecting it to be terrible. It actually is pretty good. But the component that is just kind of non-negotiable is there has to be protections for participants. And I feel like the whole, like the place where all the like liability concerns and yeah, but what if, is this legal, all comes from within governments, be it like state or local or health department governments or like funder governments. And it's about their own liability and their own risk. And it does not address the risk and like the concerns. It don't really center the risk for people who are using drug checking services. And so there is language in that in this model legislation. But I would just say that, like, if I were being a policy advocate or activist, I would like that would be a non-negotiable if legislation attempted to cut out that component of state legislation. And again, the best thing to do is to get rid of paraphernalia laws. That's the best, broadest thing to do, is just knock it off. Let's just go ahead and scratch those. So.
I'll also say too, like, I know that as we wait for, guidance from the feds around, sort of different models. And I do think they break it down pretty like specifically, here are all the different options that you have, including, eradicating paraphernalia laws, which is number one option in my mind, which are completely anti-public health. But I've read some, I was just trying to find it online and I can't, as I'm sort of frantically typing. There's been two publications or things that Corey Davis, who's an amazing researcher in the harm reduction public health world, analyzing both like California, I think, legislation. Then just recently, I think as of like the 1st of June or the beginning of June, wrote a paper on, or white paper on, like the legality of drug checking in Illinois. Both, things that I think with some Googling you could probably find. But yeah, I think the most recent document on the Illinois law is on the Network for Public Health Law website. So it's something that, folks might want to look at and reference as they're kind of continuing to talk with their legislatures. Because, I understand not wanting to wait until we sort of have this formalized guidance. I mean, there are resources out there that can help advocates who are looking to kind of pass laws now in their own states.
Awesome, thank you. So just on participant protections, and then we'll kind of go back to the chat, and if other folks have questions, jump in. But Maya, I know you had mentioned the other day about, ensuring that law enforcement, like if you're implementing drug checking services at a program, like ensuring that there are protections in place. So like this data can't be subpoenaed, like law enforcement wouldn't have access to this data. Ensuring that your participants know that and like feel comfortable using these services because it won't be shared with those folks. I think something was mentioned about like IRB approval as maybe like something that ensured some participant protection. So I was just wondering if you could maybe elaborate on some of those things a little bit more in detail about things you can do to protect participants.
Yeah, sure. I'm part of the research and surveillance unit in the health department. So I had a lot of support in formulating this and submitting it from people who are more used to doing that. This is my first time submitting one. But part of that process was writing a protocol. And then, I think something that's important when writing up the protocol is to, be careful with the language that's used. Like I'd use the language of drug trash a lot, drug residues, so that they don't get scared, I guess. But also just to consider that some of the language that is used can sometimes make the programs more restrictive. And so like one of the things that I wrote into my IRB was to be in a private room. And now that we're looking at different settings, like our overdose prevention center, potentially to have drug checking in, if we want to be in a more communal space, and that's something that we're restricted to. We have to stay within, the confines of what we wrote in the IRB. But yeah, you basically write your protocol, you write an application, and any associated things. Like we created a flyer that the SSPs would post around their program so that they can let the participants know that this is happening. And once that was completed, we had to send it to our legal team to review, and then they would check if there's any questions or any things that they felt uncomfortable about, which they didn't. It was a pretty easy process to move forward. And then after that was submitted, then we had to go to, what is that? It's called a certificate of confidentiality, and I think it's through, it's some federal, oh, the NIDA? Is it NIDA? Someone help me. But it's one of those federal regulatory people. I'm going to Google it right now. And then we applied through their NIH, maybe. Yes, NIH. Thank you. And I'll put the link in the chat of what that is. But it was a really easy application. We just sent over like our abstract and what the study was and things like that. And it gives an added layer of protection so that our data can't be subpoenaed and our participants can't be like prosecuted through the study.
And the thing that we noticed is that participants were both, like, basically participants were either super duper excited or kind of didn't care that much, right? Like sort of fell in like two categories, but everybody was initially skeptical. They were like, let me get this straight. You want me to bring drugs publicly, you're not even being secret about this thing, and you think I'm not going to get busted? So everything that can be possibly done, like, because we all know that like it doesn't matter the like actual reality of getting busted. It matters if people think they're going to get busted, and that affects people's decision making to use the services. So we really have to do like everything we can to really kind of promise that, you know, that they're not necessarily, that we've done everything to keep them from getting in trouble, and that their information is not going to make it to the cops. Which also means that if there is a public health, public safety partnership that involves things like ODMAP or HIDA, and HIDA puts out a press release about how they're collaborating with the needle exchange, this is gonna be a problem. And it's gonna be like not a good look, you know? And so, or, you know, not even just HIDA, but like crime labs or it, you know, et cetera. Like anything that seems law enforcement-ish, is going to affect participant perception of safety.
I'll say too that like it was a little bit different on our end, even though we're sort of peripherally collaborating with a much larger research project. We did not have to go through an IRB process. We sort of implemented this just as one of our public health interventions, or one part of our, or one piece of our overdose prevention programming. In the way that the intervention is structured, it also comes along with harm reduction counseling, like we talked about yesterday. And there is a very strong argument to be had that that is PHI, right? So that's health data, that's health information, which is also protected. Like all the other information out of an SSP that includes like individuals' information is protected. And, you know, like it stands to reason that that also should be protected. And so having, you know, IRB coverage or protections is great, but I also think that like if you're going to implement this in a health facility, you know, I think there's a strong argument to be made that this should not be, you would be able to, even if the police came in and said, give me your Excel spreadsheet, like I'd be like, well, where's your warrant or whatever. But one other thing that I want to say about like trust building and like people like availing themselves of the services, like our people were really excited about it. But it's really important to think about like who you're training as drug technicians, right? So like you want to train the staff that are on the front lines that like already have relationships, and you want to train staff that are reflective of the population that you serve. Like I am the whitest white girl on the planet. Like I can speak white girl Spanish, but I am the whitest white girl. And so like, you know, we weren't seeing a lot of like people of color coming in and getting their drugs tested. And we were like, listen, like we need to start to, we have a very diverse team. We should have a diverse team of people that can operate this machine and who can engage people around this checking service. And so, you know, we have an additional drug technician who's Black. We also are working on getting some of our Spanish speaking staff all like up to speed on the machine. And that's made a huge difference. I'll just kind of give you an example. We had a 65-year-old Black man come in that I kind of knew from outreach in certain neighborhoods. He had never come to our drop-in before, but we knew him from this one particular neighborhood in Boston that he had engaged with some of our other staff. And he came in, he's like, I have some stuff I want to get tested, and never done it before, but Kenny told me that I could come in and get this tested. He sits down with me, he's like real skeptical of me, and I'm like, I know Kenny. I'm like, Kenny's like one of my people. Like, I know that I look sus, but like I can definitely operate this machine. I promise you. Like, if Kenny told you to come here, then he trusts me and we can do this. And it took some convincing. We sat him down, gave him the results. That man had never had Narcan before and has been sniffing dope since like 1965. So like, this is a really important example of like how important it is to have staff that reflect the population of people that you serve. Like 39% of the people that we serve in Boston are people of color. And they're not always going to open up to, white staff or staff that don't come from their neighborhoods or staff that don't look like them. And so like understanding that it is very important for you to have like, and you can train people who are not like do not have chemical backgrounds or chemistry backgrounds in this machine, but you also have to make sure that like you're training a diverse array of people to do this machine and to engage with people, because that's how you build trust, like trusting relationships with folks.
Awesome, thank you. There were a few questions about just like benzo test strips or other types of test strips. I know it was answered where to purchase them, but in terms of experience using other types of test strips or pros and cons, or incorporating those into other drug checking services, which ones are available, any experience using them?
Sure, I can start. I put a resource in the chat as well. I think I went a little back and forth when I first started using them because we weren't sure what the utility of benzo test strips in our particular supply would be. And I reached out to Sam Tobias from BCCSU and I asked him like, what do you think? And, obviously their drug supply is really different from ours. In British Columbia, in Canada, like upwards of 70% of their dope has benzos in it. So their recommendation to us was, I don't know what your supply looks like. You guys might have benzos in your dope too if you've never tested it. So maybe you should just, don't waste your benzo test strips on things that are stimulants, unless the person's like, I took this and I felt really like I nodded out real hard or something. And then if you want, you can make that judgment call. But they suggested for us to test all of our dope with benzo test strips. And so I've been doing that. None of our dope has benzos in it. So, we might switch over in the next, we're kind of like in a pilot phase. We're just like writing protocols as we go. But we might change it to just using benzo test strips whenever there's a benzo or, a suspected benzo that's brought in. And what I found is that the benzo test strips are not as sensitive as fentanyl test strips. Like the fentanyl test strips, you can use bigger dilutions, and sometimes it's not like, it's helpful to have instructions, but it's not as finicky as the benzo test strips are. So for me, I use 2 milliliter snap tubes, and I put the water in those, and then I do this with my hands. I warm them up to try to get the benzos to dissolve as much as possible. And then I dip it and then I use it. But what I've seen, or in my experience, the benzo test strips are not super, they're like iffy when it comes to detecting research chemical benzos. So I think in that resource that I put in the chat, it's like it can detect research chemical benzos something like 20% of the time. So there was an example that somebody brought in a press pill that was supposed to be Xanax. And when I tested with the benzo test strip, it came back negative. Both times that I did it, I tested it twice, which to me is indicative that it didn't have alprazolam, because the benzo test strips are pretty good at picking up pharmaceutical benzos. So whenever somebody brings in a pill that's actually a prescription, it tests positive. And then when I tested it on the FTAR, then it came back as having a Tzalam in it, which is a common research chemical benzo that is not, Xanax, Klonopin, things like that. But those 2 resources that I put in the chat have been really helpful for me in terms of like learning about how the strips work, the problems that they have, and something that I would encourage folks to read if you're looking for more information.
We use the test strips. We don't use the benzo test strips on dope for the most part, but that's not to say that we won't. So, we're constantly monitoring the LCMS, GCMS results. We're also like looking regionally, like what other people are seeing. So like if we're starting to see, you know, Tisalam or Bomazolam or flualprazolam, which is one of the most like sort of prolific synthetic benzos that are in our drug supply right now, especially in pressed pills, then we'll definitely start using them. But in general, like on dope samples or on like street opioid samples. But in general, if we're testing, we want to be able to do something for somebody that brings in a Xanax or a Klonopin that they think might be pressed. It's very difficult to see benzodiazepines on the FTIR. If I am seeing them, then I have reason to believe that there's a lot in there and it was likely not coming from a pharmaceutical company. So sometimes like when you see a lot of them, when you actually see it on the FTIR, I get a little bit, you know, kind of nervous. But oftentimes when people come in with pills, we can't give them a ton of information. We can tell them what it's cut with. It might be like microcrystalline cellulose. It might be lactose. It might be, you know, dicalcium phosphate, which are all normal cuts in pills. And sometimes we can make educated guesses based on what the cuts are, whether or not it's a pharmaceutical. But most of the time, people on the street who are pressing pills can get their hands on the same cuts. And so it's really difficult to tell definitively. But the one definitive thing that we can do is like, say, hey, listen, like here's some benzo test strips, here's how you use them. It differs a little bit from fentanyl test strips because as you know, Genetics was saying that most benzos aren't very water soluble. And so if you're going to be, and you have to use water to test, you know, to use the test strips in. So we have those little kind of like microcentrifuge tubes. I forget what they're called, but I think you get them basically anywhere. And we just like shake them like a manic bartender shaking a cocktail for about like 35 seconds. And then use the test strips. And if it comes back negative the first time, we always use a second one. There have been instances in which like we have had someone bring in a pill, didn't see anything really active ingredients on the FTIR, used one benzo test strip, came back negative, and then used another benzo test strip and it came back positive, and that ended up being a Tisalam. So Genetics is right in that it's less sensitive than the fentanyl test strip. And so if you're budgeting out, like, and you see a lot of pills, I would say budget 2 to 3 test strips per pill that you want to test.
I was also reading something about like having to use warm water. Is that why you're like shaking it with your hands, or is that's the best way you think to warm it? Yeah.
That was what I saw in BCCSU's instructions in the community resources, because it's just hard to get warm water when you're like doing a lot of tests at once, unless you like stop to the bathroom and then like, you know, get warm water that way. I guess you could do that. But yeah, in their instructions, they said to put it in between your hands, and like the heat of the friction that your hands create, if you do that for about 2 minutes, it can
Okay.
warm up the water. But
Alright.
I suppose like if you can get access to warm water, that might work as well.
Thank you.
So reminder, folks can unmute and chime in and ask questions. I did have a question. So just about data, Maya, we had kind of talked about. So why does postmortem toxicology data and drug checking data differ so much? Whether there's like a lot of stimulant fentanyl related deaths or not between the two data sets. We'll talk about it.
Yeah, I mean, it's been so funny. Every single time we like talk about drug checking and the results from drug checking, we, you know, kind of consistently say like, while it is possible, it is uncommon to find fentanyl in your stimulants. And somebody always comes back and says, well, there is about 80% of our methamphetamine supply has fentanyl in it. And, you know, we're sort of like, I mean, that's just nowhere else is seeing that. So like what's going on? And sometimes people are actually referring to their postmortem toxicology data where 80% of fentanyl of methamphetamine involved fatal overdoses also are fentanyl involved fatal overdoses. And so there's a lot going on there. All we can really say is that this is, you know, this is the more fatal combination. We cannot make assumptions that the methamphetamine had fentanyl at the, you know, when it was consumed. Like perhaps it was polydrug use, perhaps it was somebody using an illicitly acquired alprazolam following some methamphetamine use, but the alprazolam was actually fentanyl. You know what I mean? So like there's so many different possible explanations for the large proportion of stimulant fentanyl fatalities that is just sort of lost when you just look at the data. And what the real-time drug checking data is showing us is that we don't see that much. And so, you know, there's also possible explanations for that, is that the people who you know, who we lose to fatal overdoses that involve stimulants and fentanyl, maybe they're not the ones who are accessing drug checking services. That's a possibility. But what is also a very likely possibility is that when we're looking at fentanyl test strips and you're relying solely on that there's some user error. And when we look at postmortem toxicology and you rely solely on that there's some assumptions errors. And unless we can actually really triangulate and get more than one source with more than one technology type to say for sure that we have 80% of our methamphetamine has stimulants in it, I think we really should be sort of crossing out the more logical and likely rationales. Because if there's a place that has, I just keep going back to this because this is the most recent, you know, sort of debate I got into, is this 80% issue. If indeed there's a place that has 80% of their methamphetamine has fentanyl in it, that is a wild outlier. I mean, we really want to know, but that's an incredible outlier. And when we have something that is so much of an outlier, it's worth confirming indeed that it is an outlier, as opposed to and scratching off the other possible explanations first, which are, you know, and when places have been able to use advanced technology, real-time harm reduction-based drug checking, we found indeed that there's not that much in stimulants. And so I feel like every place I've ever been that pre-launch, we're like, there's fentanyl in everything. And then post-launch, oh, there's not fentanyl in everything. So I just, you know, when we hear anything, when it comes to drugs that is wildly scary or dramatically, you know, framed, I think we should all have our skeptical hats on. And it just seems like the kind of appropriate process to, you know, cross out some more reasonable rationales. So that's my thoughts. Anybody else? I also, just in a slightly different subject change, I noticed that our colleague our Canadian colleague Karen McDonald is on, and she runs a fantastic drug checking program in Toronto. And Karen, I don't know if you're like fully listening, and I don't want to put you on the spot, but if you are listening and you want to talk at all about some of the training that y'all have done for your team in terms of communicating results to participants, is that anything you feel like talking about, since I feel like you're really good at that?
Oh, I'm here.
Cool.
Hey, thanks so
much. Sorry to
for
put you on the
interesting.
spot, but
Oh,
I
yeah.
appreciate it.
No worries at all. Yeah, so we the model that we're implementing here in Toronto is what we call offsite drug checking. So what we're doing, and it's a model that we're piloting. So we have samples being collected at 5 harm reduction agencies in Toronto that offer supervised consumption. Those drug samples, which could either be an actual substance or equipment, like residue on used equipment, are going along then to a clinical lab every day by bike courier, where they're then analyzed using either GCMS or LCMS. So these are at hospital labs that already have these instruments. And we are, we're very fortunate because those are super sensitive instruments. And so we're able to provide very good information about what drugs are present in the sample, and also how much by applying a quantitative method. But unfortunately, there are longer turnaround times because the samples have to be sent off site. So what's happening is the labs then are analyzing the samples, communicating results back to the harm reduction agency within about a day. And then that's where the results are communicated to service users. So what we have tried to do, because the instruments that we're using are so sensitive, there are just so many drugs that we are finding. We've identified over 350 unique drugs at this point. And as much as, we're relying on harm reduction staff who are so well versed when it comes to drugs, like so many of these drugs, they're just like, what the hell are these? So we're kind of trying to just do a lot to, just provide really brief definitions of what some of these drugs are on our website, which I can share in the chat. We have like a drug dictionary. And then we're just trying to provide, really not reinvent the wheel, just pull together information about what different drug combinations mean, or, at least what class are all of these various drugs that we're finding, and kind of, what that means and what interactions between them mean, and that sort of thing. So that really all runs through the harm reduction staff at the supervised consumption sites, but that's kind of a bit of what we're doing just to ensure that, because when folks receive a result and there's like 10, they bought fentanyl and there's like 10 drugs in it, and maybe fentanyl is one of them, but it's also like several benzos, several other synthetic opioids, and then like a number of stimulants and all these other things, just trying to equip people as much as possible to try to understand what that means.
That is such a good point. Thank you. And appreciate you sharing those resources. I was just having a conversation. I mean, it really does get complicated when we're looking at all of these different compounds. I was just having a conversation with a friend who got some results, and it was and their substance was, it had 6-mAh in it, heroin and acetylcholine. And she was like, oh my gosh, there's 3 things. I thought it was just heroin. And the truth is like, that is just heroin, really, in a way, right? Like 6-mAh is a metabolite, acetylcholine is, I mean, it's like, it's not like this is the more complicated current iteration of heroin. Like we weren't always checking heroin. And even when there wasn't fentanyl in the drug supply, like this would have been a normal heroin result, right? And so the complicatedness of having so many different substances. I mean, I think 4-ANPP is another example that is like kind of, it's just like, for all practical purposes for people who use drugs, it's just like kind of a part of a fentanyl, right? Like it's not necessarily this like terribly complicated new substance. And yet when you see the readout that has a dozen different things, it looks super complicated, I don't know.
Yeah, it can also be really tricky just because drug checking is super complicated, and with the instruments that we're using, like oftentimes they're identifying like byproducts or metabolites or things that like really what we have determined with our service user, they're actually just complicating the results. Like our service users are overwhelmed, right? Because sometimes, especially when we're analyzing paraphernalia, if it's or used equipment, if it's been like reused a number of times, we literally could find like 15 different drugs in it. Some of them are active, some of them aren't, and it can just be totally overwhelming. So yeah, there's a big learning curve, and what we've done with our community is kind of determined like what actually adds value here and what doesn't. We of course collect and store all of the data, all of the compounds that we can confidently identify, but then when it's actually, we kind of pick and choose. Like when we're sharing information with service users, we try to keep it simple. Like what are just the things that they would care about? And then, then when we kind of develop reports, or if it's more of like an academic publication or something, maybe we'll include all of the different things that wouldn't add as much value to the individual person. But yeah, it's tricky, and the drug market changes so incredibly quickly, and it's really hard for the technologies to keep up. Like even for us, like to quantify certain drugs, to determine, how much of a certain drug is there, that's actually like not, to develop that method is a lot of work. And I feel like we're like, oh, okay, atizolam, we're going to quantify that. By the time we develop the method, it's like, oh, atizolam's actually on the decline, and it's, fluoprazolam that's actually the most common benzo. And we're like, oh no, okay, we're going to go do that. So it's tough, but still also important.
Yeah, and I just want to piggyback on a bit of what Karen was sharing, like something that I was really surprised at, which ended up being the most difficult part in terms of being trained up to identify what's in substances, is mostly with the dope that we have. So like our dope can have between like 2 things in it, like mannitol and fentanyl, up to like 6 to 7 things in it. And those more complicated samples required a lot of training from someone who can sit there and be like, no, actually you have to do like, there's a trick here, and all these little tricks that like you don't just learn. Like somebody has to walk you through that process with the FTIR specifically, like to learn how to figure that out. And the more things that are in the sample, the more difficult it can be to parse through the results and figure out what's in there. And then you have to take that information and then like figure out how to explain it to someone, be like, well, there's these 6 different things in the dope, and this is this, and that is that, you know, and then that's also harm reduction information, which a lot of us may know that information, but in terms of communicating, it's really important to have, I think, the support from other drug checking folks that have been doing this to help people like think through what is important. But something else that we've also been thinking about, or that we've been doing as part of our drug checking service, is when we get our confirmatory testing results back, we do get a lot of the metabolites and or the precursors and the things like that that come in, and we have had to communicate with our toxicologists and be like, what is this? Should we talk about this? Is this important? And then we end up trimming it down for when we, you know, give the results back to the SSP, they can actually use it in a way that's helpful for them. But like Karen said, that if we were to communicate it to clinicians or something, then some of the things that we don't share with the program, we would keep. Just reiterating the importance of working with other harm reductionists as you're putting a program together and not trying to do this in a silo.
I was just trying to type the answer to this question. I just think it was a little bit like complicated, and I think, you know, Genetics probably has a different approach to this, but like, so the question was, if you're using the Opus software, which is the software that's you know, packaged within the machine and the laptop, like when you're using a mixture analysis, which basically is like a autopilot analysis that the software will do and say, hey, like spits out like, I think it's 30% lactose, 70%, you know, mannitol or whatever, you know, and then it'll kind of break it down. Versus, you know, like having the whole scan, running it through various libraries, depending on what you're looking at. So if you're looking at pills, you want to have the pharma libraries on, but also some of the other, like the 3 major kind of like illicit drugs, street drug, precursor, drug libraries, which is like the 3 libraries that we primarily rely on, which is the BCCSU, SWIG drug, and Tic-Tac. When you do a mixture analysis, sometimes there is a component that you can't identify. And, you know, like you've done every trick in the book. I mean, sometimes you could just run a mixture analysis for fun, but it's not always accurate. Like the machine is kind of dumb, as like Sam Tobias has said a million times. Like sometimes the machine sees wild stuff that you're just like, that is absolutely incorrect. But once in a blue moon, you know, running the mixture analysis has been a little bit helpful in terms of being like, am I looking at xylazine? Am I looking at something else? I can't really tell. As somebody once told me before, like you sometimes will start like looking really hard at it, like a Rorschach test, and you're like, what am I seeing here? And somebody said, like, you know, like you already subtracted 3 components. What you're looking for is a spot in a windstorm, you know, which is like my favorite, you know, saying ever now. But sometimes the mixture analysis can be helpful, but for the most part, we go pretty systemically, like we do the spectrum searches. One of the tricks that I've been using a little bit more recently is sometimes the machine won't give you what you're like you think or you know is there. So if I'm like, I know that there's fentanyl in this, I can see the signal, but the machine isn't giving that as an option. You can actually manually search for that signal or that kind of fingerprint, open it in a different window, drag it over to your initial spectrum. This is like Bruker 102 stuff, but these are tips and tricks that are really, really important as you're trying to figure out like how to navigate the software, which was not built for us, right? And not built for this specific purpose. But this is why it's so important to have a learning community, because otherwise, like you might run a test on this machine and it'll tell you that there's like cashew nut, licorice, and, you know, you do the mixture analysis and it tells you like, I don't know, tears from Jesus Christ are also in this drug, you know, like it just tells you crazy things. But, you know, like, for example, I'll give a really quick example. So sometimes we would see this kind of like peaky signal, like right around, like on the left-hand side of the spectrum, like these 2 little peaks. I'm like, what the hell is that? And it was typically on pills and it kept coming up as like paraffin wax. And I'm like, bro, like, what is this? So I like sent it over to Sam and I'm like, what am I looking at? And he's like, that's basically just like the oily coating, waxy coating that's on a lot of pills or a binder. And you're going to see that a lot. It could be like stearic acid. It could be something else. But now when I see that, like, I'm not like trying to like figure out what horrible thing is in that sort of range. But these are tips and tricks that you only are going to get from somebody who's been using this particular machine and this software for a while.
So we have a few minutes left. I did kind of want to ask, I know we're talking about more like advanced technology stuff, but a fentanyl test strip question, because I know there's a lot of programs that don't have access to other more advanced technologies. So when starting to like distribute fentanyl test strips to participants, I know we had talked about, this is different from naloxone distribution in that like you're only wanting to give fentanyl test strips to people who use drugs and not like friends and family members and stuff like we do with naloxone distribution, but which I agree makes a lot of sense. But when starting that type of program, is there any guidance around like how many test strips to give to each person? So like, obviously if they have people they can share and then, secondarily distribute with folks. So I know it would probably vary case by case, but, it with the knowledge that like there might be user error, they might need to use more than one strip if it gets messed up. So like not only distributing, one or two to people, is it every time they use because of chocolate chip cookie effect stuff or only when they get new batches? Like what is some of that guidance, or like is there any type of average number of strips to give to people? I'm sure it varies, but just stuff to think about with that.
I can take a first pass at that question just from like a higher level, I guess. So at the health department, we were working on a couple of pilots of doing fentanyl and test strip distribution in different settings. Some of the settings are nightlife organizations like clubs. Some are community-based organizations that are like health centers. Some are just community organizations that are like cultural centers. And some are harm reduction or harm reduction adjacent organizations. And generally what we tell them is it's up to the program themselves. The minimum should be 3. And for us, that's what we typically tell people. And like between 3 to 5 strips at a time, we think is good, just because it gives somebody room for error in case they need to use another strip, but also like an extra one just in case. But we generally tell the programs to think about how often they see their folks. So like, if somebody comes into the office every day, maybe they can just take 2 at a time and they'll be okay, or 3 at a time, depending on what stock you have. But for people that know that they see their person once a week, maybe once every 2 weeks, once a month, it's okay to give 10, like whatever. But also one of the things that our organizations have been giving us feedback on is just that they don't have enough fentanyl test strips. And we're giving it to them for free from the health department, but we don't have a big enough budget to meet the demand, because like obviously the demand is huge across the country right now. So I think that's just something to consider as well. Something that we've been suggesting for programs to think about is to prioritize giving the strips to people who are likely to be opiate naive, or for people who are using occasionally, because they, are at highest risk of overdose if they were to encounter opiates in their supply. So that, and I feel like I had another thought, but I'm gonna pause there and let other folks chime in.
I mean, I agree. I think the good rule of thumb is like as people request them, but I know there's a debate on, are fentanyl test strips cheap or are they expensive? From my mind, they are actually a relatively expensive thing if you think about the things that go out of a needle exchange program. So there's always just the practical reality of resource scarcity. And so I think at minimum, a good rule of thumb is to be able to test every single new batch as a person says, apply, however that applies to that person. Like, are they using a new batch every single day? Well, then give them as much as they need for every single day until they come back. So I don't know. That's my opinion.
Yeah, everything that, Maya and Alex just said, considering, we have a lot of folks that do secondary distribution through the exchange. They come in, they get like a box or 2 or a case of needles, they come back, they bring some back maybe, and we give them more. I mean, honestly, I think the same, if, funding obviously permits, to keep that in mind. If someone's like, hey, listen, I have a network of 20 peers in an encampment that I want to show how to use these fentanyl test strips and I want to distribute them, and that peer or that person who's doing this secondary distribution is your only connection, like, of course, like, you just give them what they need. I'm not going to lie and say that I haven't given out like a box at a time when the situation calls for it, but we're also really fortunate to have a decent amount of funding, and not everybody is in that same kind of boat.
Thank you. Yeah. So we are just about at time. I wanted to give our panelist folks any like closing thoughts or any resources you wanted to plug, or like Learning Collaborative you wanted to plug, or anything like that for folks to get more information on. And we will be, posting this on our website. Folks can contact NASDAD as well. I'll put our email in the chat for more questions as they come up. Final thoughts? No?
No, it's great to be here. This is obviously an enduring and ongoing conversation. So I think that we're just going to need to continue to be like in frequent, regular communication as we roll out drug checking services as they're in this iteration in their infancy in the US, acknowledging that there has been dance safe and drugs data for many years, but this iteration is new. So looking forward to being in communication.
Awesome. Well, thank you guys so much. These have been super informative and very helpful. I know I've learned a lot. I'm sure it's very helpful for a lot of our health departments and harm reduction folks all across the country. So just really, really appreciate you all. And we will chat soon. Thank you.
Thanks for having us.